Thanks for joining us again. This is the Piedmont Napa Cardiology Conference 2018. My name's Prashant Kaul. I'm an interventional cardiologist at the Piedmont Heart Institute in Atlanta, Georgia. I'm here with a very good friend and colleague, Dr. David Kandzari, who is our Chief Scientific Officer and the Director of Interventional Cardiology at the Piedmont Heart Institute. David, thanks for joining me.
Thank you, Prashant.
So you just got back from Paris. EuroPCR is a very exciting meeting. You had the privilege of presenting the results of the SPYRAL hypertension study.
Yes.
And so just to take a step back for a moment, a few years ago, 3-4 years ago, we had all started writing epitaphs about renal denervation after Symplicity. And, there was a lot of discussion about the trial design and so on. So tell us a little bit about what you think the issues may have been with Symplicity and what was done differently this time round, and then maybe discuss for us a little bit about the trial design and the results of SPYRAL.
Now, that's a great starting point from the Symplicity Hypertension 3 study. We recall in January of the year we announced the negative efficacy results. So it was a safe procedure, but it's really been a storied path of renal denervation since that time of lessons learned, revisiting and exploring the experiences in studies like Symplicity Hypertension 3, but also learning more about the anatomy, learning more about hypertension and the patient population itself. And so altogether, we specifically focused on three large aspects of how we would move forward with renal denervation. First was the patient population. We moved from a more extreme patient population with severe treatment-resistant hypertension to a much broader, but ironically more homogeneous population of patients with moderate uncontrolled hypertension on 1 to 3 medicines, for example, or coming off of medicines in a washout program versus the average of over 5 medicines in studies like Symplicity. The other aspect we focused on is how we do clinical trials. We focused on less variable endpoints like the ambulatory blood pressure over 24 hours that provides a more consistent metric of the burden of hypertension. We were more attentive to patient and prescriber behaviors with regard to adherence of medicines and prescriptions of medicines and changing medicines during the conduct of a clinical trial that further confounded the context, the background context of understanding what the device was or was not doing. And the third aspect is redesigning the procedure and the technology itself. In this particular instance with radiofrequency denervation with the SPYRAL catheter, which provided an opportunity for multiple circumferential ablations at a singular time, but also extending into the branch arteries. The branch arteries are a segment anatomically where the renal efferent and afferent nerves are more closely approximated to the lumen, and therefore, at least with this technology, provide a more susceptible target to renal denervation. And so with that background, we embarked on the SPYRAL programs. And really, SPYRAL is a 2-phase program. We call it the on-meds and the off-meds program. And the first to finish was the off-meds program, which is very analogous to how pharmaceutical agents are presently approved in the United States by the Food and Drug Administration. There's a washout period where patients come off of their medicines. We allow their blood pressure under careful supervision to escalate. The patients in the drug realm are randomized to placebo or an ACE inhibitor, for example. But in this case, the patients were randomized in a sham-controlled procedure to either the sham control or alternatively to renal denervation. Those data we presented last year at the European Society of Cardiology meeting and have been published in The Lancet showed that renal denervation compared with a sham control was biologically effective. It was the proof of concept, the proof of principle. We achieved significant, meaningful reductions in blood pressure, both by office measurements as well as by ambulatory blood pressure with renal denervation. And then the next transition to that was to think about renal denervation in a context that might be more representative of clinical practice, in which clinicians might think about integrating drug therapy with a device therapy for uncontrolled hypertension. And this was the on-med study that you referenced, recently presented at the EuroPCR meeting. In this type of trial, patients were on 1 to 3 commonly prescribed antihypertensive agents, an ACE inhibitor or ARB, a diuretic or a calcium channel blocker, or perhaps a beta blocker, so routinely prescribed medications, but still had a persistently elevated blood pressure, an office blood pressure between 150 and 180, and a diastolic blood pressure of over 90, so fairly hypertensive people, despite prescription of commonly used medications. And once again in this trial, renal denervation compared to the sham control group was associated with quite profound, meaningful reductions in blood pressure. So over 24 hours, for instance, the ambulatory blood pressure was reduced by about 9 millimeters mercury versus no meaningful change in the sham control group. Office systolic blood pressure was reduced of a similar magnitude. And if you think about the impact of this magnitude, this is similar to typically 1 or 1.5 pharmaceutical agents of what they can achieve with regard to blood pressure. But moreover, a 10 millimeter reduction in blood pressure, in the systolic blood pressure, irrespective of the starting point, translates to about a 10 to 15% reduction in mortality. It translates to a 25% approximate reduction in major cardiovascular events and stroke as well. So we're very excited about moving on to the next steps of this therapy, which is now the ongoing pivotal trial, which is the SPYRAL Off-Meds pivotal study. We're doing the same trial, leveraging the data that we had in the off-meds population for hopeful U.S. Regulatory approval, but it's an international trial that will further inform renal denervation in uncontrolled hypertension. And then we're right now in the planning phases of a similar large study, but in the on-meds population as well.
Fantastic. And the timeline for that?
The pivotal off-meds trial is presently ongoing. It's ongoing in the United States at centers like Piedmont and others, as well as internationally. The forthcoming planned study in an on-meds population, I would hope will be within the next 6 to 12 months.
And then finally, what do you think the implications are for patient care, and when do you see that coming into play?
This is an often discussed question, especially at the EuroPCR meeting, because I should say that not only did we have positive results with renal denervation using radiofrequency ablation, but another program called Radiance HTN Solo with an ultrasound-based technology showed very consistent findings in blood pressure reduction with a very different method of renal denervation in an off-meds population. So we're starting to build this consistency of evidence, revisiting renal denervation in a very positive way. With regard to clinical practice, the first part is commercial or regulatory approval, and that still is a ways to go. And so hopeful with continued promise of renal denervation and with the hope and potential for successful results, enveloping this into clinical practice, I think, and how it's used in clinical practice will be the next phase of study. For patients like those in HTN on-meds who are taking medicine but still not at control. And then this whole issue of patient non-adherence or patient shared decision-making about whether to take medicines or the alternative of device therapy, I think will come into play.
Fantastic. Thank you. Renal denervation is still alive.
Thank you.